there are a couple people from the public here. Would anybody like to make a comment on any item that is not on the agenda? Not seeing that. I just have a very, very brief comment and wanted to congratulate both Ken and Sabrina, our interim CEO and COO. We're all looking forward to working with you during this hopefully brief period between the CEOs, and have a lot of confidence in you individually and in your collaborative leadership. And so thank you both for stepping up and for coming there. So that's terrific.
Thank you, Joshua.
Really appreciate it. Let's move on to the consent calendar. We have board minutes and medical staff credentialing, which Stacy shared with us earlier in the encrypted form. Any comments on those two items? And if not, can I get a motion to approve?
So moved.
So, second, this is Susan.
Thank you.
All in favor?
Aye.
Terrific.
Hey, Joshua, if you can hear me, would you wave at me?
We
I
can
can't
all
hear anybody.
Yep.
Oh, you all
If
can
you
hear
only
me.
wanted me to hear you, that's not
For
gonna
some
work.
reason, I'm not getting any sound, and I've been using Zoom a lot.
Yep, you're not muted. You're fine. Terrific. So I'm going to shift the agenda just slightly and ask Jen Sweeney, who's joining us from UCSF, to go next. And then we'll come back. Hopefully, Jen, you can stick with us as we talk a little bit about the actual framework, and you may refer to it in your remarks, but I figured it's actually probably makes sense to have you go first, and then we'll come back and talk about the framework for our affiliation.
I'm going to try to get on my laptop.
Okay.
Thank you very much, Mr. Chairman. And also, it's a pleasure to be here. Can everyone hear me?
I can.
As we're getting finagled on the technology front?
I can hear on my...
I'm going to mute.
Judy, you may, yeah, there you go.
Can you see the presentation, Jen?
Yes, I can. Thank you, Vivian. I appreciate it. It's a pleasure to virtually meet all of you, and I look forward to meeting you in person in the near future, and wanted to wish everybody Happy New Year before we begin. As an overview this evening, I just wanted to touch on a few topics. Next slide, please. To really just sort of briefly go over our Vision 2025 as far as UCSF is concerned, our current collaboration, and perhaps some future opportunities that we have together. Next slide. In guiding our team, we have based ourselves and organized ourselves around our vision and our values, our true north values. And our vision is really to be the best healthcare provider of service. So we really believe very strongly in that, and that just sort of gives you a visual of how we organize ourselves around all of the endeavors that we pursue. Next is a map indicating our affiliates network with the hospitals on the left-hand side and our ambulatory and physician affiliates on the right. And as you can see, we have quite a broad scope. Our network covers from the Sonoma County area all the way down to Santa Clara County right now. So we've really grown by leaps and bounds over about the last 3 to 4 years, and that's really sort of prompted a framework to develop the team, in essence. So next slide. This slide just encapsulates our UCSF Vision 2025, which calls for further integration across our network. We are really working with our partners to deliver the right care at the right time in the right place. And we're committed to ensuring no patient has to drive more than 25 miles to access care across the Bay Area. We're developing intentional strategies to support and create value for our affiliates, and we're interested in expanding primary and specialty capabilities across the network. Next slide. And with that, and with the tremendous growth of our affiliates network, we have established a new leadership team led by Shelby DaCosta, which I think she had the opportunity to present to you in October of this last year. Shay Strachan serves as our Chief Strategy Officer of the affiliates, myself as the Chief Operating Officer, Ted Abraham as our Chief Medical Officer, and Raju Iyer as our Chief Financial Officer. Our next slide. So with our team established, we have 3 guiding principles that I'd like to give a brief update on, and they are align, connect, and expand. And to align, we're focused on optimizing our culture through a dedicated leadership team and improving communication across the network. To connect, we're interested in scaling innovative solutions that promote convenient, safe care across the network. And to expand, we're prioritizing investment across our contiguous geographies. So I just wanted to touch on the next slide in terms of alignment. Our leadership team is extremely excited to expand on the management services agreement to provide leadership support and program development with you all. We have 2 key projects in place right now that we are looking to partner with you on. One has to do with a transfer command center, an air traffic control system, so to speak, across the network so that we're better able to align upfront patient placement. We have, I think, notoriously made it very cumbersome for patients to seek care from us at the Parnassus Hospital all the way into the city, and so we're seeking alternative locations to provide that care and want a command center in order to make it a seamless process for our patients. We also are extremely excited to integrate further with you in terms of our IT solutions. I know it was a tremendous lift for all of you to recover from the ransomware circumstance this year, and I know from Dr. Kidd it was really a big learning experience, and we're very interested in putting forth a proposal for additional IT support solutions to you all. Our next slide has to do with Connect. So in order to connect all of those pieces of our network, our priority is the patient care experience. And in order for us to expand upon our primary and specialty capabilities, we're very interested in actively working on digital advancements to enhance our communication through provider email so we can share ideas and best practices through the development of a navigation system. And again, back to the Transfer Command Center, we're really very bullish on trying to indicate and navigate patients where they need to seek care in the best environment possible. So we go on then to the third principle of expand. This is a table indicating the current service lines that we're providing across our hospital affiliate network. As you know, we have a partnership with John Muir, also with Washington, Marin, and Sonoma Valley Hospital. So the blue dots indicate future service lines that we might contemplate moving into 2021 and 2022. So more to come on that our expansion strategy in the future. Next is, so I think that both entities, we have a collective vision, and we really seek to enhance the quality of services in the Sonoma community by coordinating our patient transfers, I think namely, and really with an eye to reciprocity, through enhancing our physician and administrative services and developing quite a few programs with you all. And we're very bullish on increasing our patient and community satisfaction with you on patient care throughout the Sonoma community. Next, I think, is a slide that's near and dear to all of you, and it's also near and dear to us, where I think you all are very probably informed about this particular slide, and it dovetails nicely into our vision at UCSF, and we remain very excited about contemplating a outpatient center with you all. And we also look forward to working with the new CEO as you decide who that individual may be. Although I have to comment that Kelly's shoes will be awfully tough to fill. And I look forward to working with both Sabrina and Ken in the meantime to see what other opportunities exist out there. Next slide. So this is really sort of going over an outline of our expanded relationship and what it may mean for both entities, both Sonoma Valley Hospital and UCSF, in implementing our strategic plans. We believe it'll drive further alignment with UCSF Health, and it will provide an opportunity for us to grow and pursue business development. And we also believe it'll enhance access to tools and resources at UCSF Health while assuming some and providing some risk mitigation for the Sonoma Valley Health District Board. The next slide outlines how the new leadership structure extension might look. We are wanting to extend our organizational structure to Sonoma Valley's executive management team. And so the CEO, in essence, will have a dotted line up through the affiliates network with the chief medical officer and the chief financial officer reporting up through the CEO as they do now. And to conclude, I just wanted to say that we're very excited about the opportunity to build and strengthen our visions into the future together. And I wanted to indicate that Sonoma Valley Hospital is a very high priority for UCSF. We really believe in expanding mutually beneficial partnerships and delivering high quality patient care to the community. So with that, I will wish you all a happy new year and would be happy to field any questions at this time.
Yeah, Jen, this is Michael Minardi. I've got two questions for you.
Sure.
Currently, many of our local residents opt to visit UCSF to get the best specialty care from faculty members due to their expertise.
Sure.
Will they have access to the same specialists at our specialty clinic, either in person or by telehealth, as we have done, as you know, with Peter Carroll? Or is the plan simply to recruit a specialist, not necessarily a UCSF faculty member, to provide service that's not currently available? And
personal responsibility. And then
is somebody else speaking?
Somebody maybe needs to be on mute for a moment.
Somebody is not on mute and has something going on in the background. Would you put your speaker on mute?
Michael, I think that we are contemplating probably a blend of both of those versions, whereby folks would have access to specialty care at UCSF through telehealth opportunities, and also decision making if it's more invasive to go into the city to obtain that care.
Okay, my second question, is it possible to integrate local physicians into the EPIC network for better coordination? You talked about the transfer of care. This would be important for patients being transferred back to the community from UCSF after a hospital stay. We did that.
Sure.
I was in practice in San Mateo for 40 years.
Sure.
Sutter did that with EPIC, with all the local physicians. It made a big difference in terms of coordination of care from the hospital back to the local physician setting.
Absolutely, it's a great point, and we are contemplating the installation of EPIC with our affiliates. And I think that that would serve us really best in terms of streamlining that care and making sure it's seamless to our patients and also our providers. It also offers a communication platform, as you know, so that the referrals go back and forth, and the communication and the details regarding someone's diagnosis are right there in the same chart. So we are looking at that opportunity with Marin Health and with a bolt-on to Sonoma Valley as well. We're trying to make sure that the cost structure of it isn't so much that it overwhelms a smaller facility like Sonoma Valley. So we're interested in trying to consolidate the project and then put forth a proposal to you to install EPIC.
Sounds great, thank you.
Other board members have any questions or comments? I've got one, but I'll hold.
Yeah, this is Bill. Yeah, hi Jen. Can we go back to the slides? I've got comment and questions on 3 or 4 of the slides.
Vivian?
Is that possible, Vivian?
Sure. What page do you want to go back to, Bill?
Well, I want to go back to, well, the pages are, I go back to slide 14 as numbered when it's displayed. And the question was about the command center. I noticed that there was a notation there about Sonoma Valley Hospital being some kind of possible pilot. Can you elaborate on that?
Yes, we are right in the midst of, or I don't know that it was slide 14 actually.
Oh,
It's
I'm sorry,
probably
that was
prior,
slide
right?
8. I'm sorry,
Okay.
I'm looking,
Sure,
I went,
sure.
yeah, slide.
Our we are endeavoring. We're right in the middle of a process improvement plan right now at UCSF because it has been determined it is awfully cumbersome to have patients seek care at Parnassus all of the time, and some patients and quite a few patients could be receiving care in their own communities and closer to home. And with that said, we're interested in developing an air traffic control system of sorts, whereby we would know what bed availability we have amongst our network so that we could properly transfer or have a patient seek care at the right place at the right time. So with our transfer center endeavor, we have we're conducting a pilot right now to try to make sure that we have all of the necessary resources and staffing in place to get that accomplished. And we're venturing on a pilot with our neurosurgical department, if you can believe that. They're very interested in partnering with us to make sure that we're accepting patients with a yes culture, and that we're identifying patients that may remain, like for example, if we have a patient requiring a craniotomy that needs such in Marin, we're able to provide that service at Marin Health rather than having the patient travel to Parnassus. It's just better for the patient. So really interested in that streamlining and coordination of care throughout our network. And we're a little bit choppy right now. And so we're really interested in connecting all of those dots through technology and through our transfer center endeavor.
So how does Sonoma Valley Hospital come in as a potential pilot?
Well, what we would do is we would present a proposal to all of you to see how you would like to participate in the network and identify opportunities where it would make sense to have folks stay at Sonoma Valley Hospital or seek telehealth specialty care or be transferred to Parnassus with criteria, of course,
what's the time horizon on? Yeah, what's the time horizon on making that proposal? Any rough time horizon?
I would say in the next 12 months or so. That is my hope. So.
Hey, Bill, can I sip on this just for a second? This was one of the areas I wanted to ask about, and then you can ask your other questions.
Sure.
So, in this case, is this for stay or for procedures? And if they're procedures, are they inpatient or outpatient procedures? Have you guys narrowed this down a little bit?
We have narrowed it down. It would be for inpatient procedures to start. Okay. Yes,
so
we're not gonna encapsulate the whole entire world with it. We're gonna start small and then expand from there as needed.
And would the UCSF surgeons or procedural, whoever the doctors are, be doing the procedures, or would this be things that our doctors that happen to be local in Sonoma would be signed up to do?
Both.
Okay.
Both.
Okay.
Depending on the service line. We'll have to go through an inventory of the service lines to determine what's the best case scenario for the service line.
And I'm assuming these are not emergent care activities by and large, or is that not true?
Some are.
Some are.
Some are. If there's a neurosurgery patient, perhaps it's urgent. But if it's a cancer patient, perhaps it's not and can be scheduled.
Right. Okay.
Depending.
Sorry, Bill, I'll give it back to you. I thought it would be good not to jump around.
Oh yeah, no, that's good. Let's go to slide 10. Jump there. Yeah, and this is just an editorial suggestion. If you would use contrasting colors here, like a yellow for one of those dots. Sometimes in PowerPoint, as you know, when you use color, don't come across that well on projection. So maybe I'm just old. I had a hard time figuring out the green.
Thank you
But,
for the feedback.
Suggestion for the future.
That would be the
Okay.
suggestion, to change green to yellow.
Well,
Or
maybe,
blue to
well,
yellow.
I would say anything that's a go, have a green. Anything
Yeah.
that's future potential, a yellow. But that
Okay.
way you'd have to change them all. But that's, anyway. Going
Thank
on
you.
to, yeah, slide 11. I think it is, yeah. The next one. Let's see here. Oh yeah, elaborate a little bit if you would about out-of-area transport
Yes.
of patients and facilitating the transfer of patients. You know, we have a fire and rescue partner, if you will, not formally actually by document or anything, but an organization here that's just a couple of blocks from the hospital that I'd hope we could do more with. And they're involved obviously in transportation, especially sometimes there are patients who, for various reasons, they can't bring to us. So they do bring them elsewhere. So can you comment on what you mean by out-of-area capabilities are needed for, don't have our own ambulances?
Yes, we're seeking to expand our transportation relationships. Actually, we have, you know, a fair amount of folks that are transported within San Francisco County lines, but we are really looking at some additional opportunities for transportation of patients via helicopter and also other ambulance opportunities as well. So would be interested in talking with you further about the fire and ambulance team that you have located in Sonoma and seeing what synergies might be brought to bear.
So Jen, I thought this was more about,
Yeah, I really would suggest.
I guess I was gonna say, I thought this was more about bringing patients back to Sonoma after they had had procedures
It is.
in the city.
Well, it's both. It's identifying the patients that may
Sure.
need tertiary and quaternary care to be brought to Parnassus, and then also returning the patient
Right.
to the community for follow-up care and additional services. So it's really the reciprocity mechanism, as it were. And I'm making sure, going through all of the transfer agreements we have with various organizations and hospital systems, as you can well imagine, I really am trying to make sure that all of that reciprocity language exists so that it's more convenient for patients to seek the follow-up care that they need and not be stranded in San Francisco. Although it's not a bad place to be, but
Far from family and home.
right, far from
Yeah.
family and home where the true healing occurs.
Right.
Well, I will send to you the contact information for the chief of the agency here in Sonoma.
Okay.
He's got quite a broader vision beyond the traditional and conventional for his capability, and runs a very good shop. And I don't know what his utilization is, but I think it would be worth speaking with him about that. So,
Okay. I would welcome that. Thank you.
oh, thanks. And then going on to slide 13. Let's see. Oh, there we go. So what's your vision for, or further elaboration on catchment area for Sonoma Valley?
Well, I think that if we're able to maybe draw on some of the, I know that your emergency department is quite busy and has remained so even throughout the epidemic that we're all encountering here. So really, I think that the catchment area being broadened would really speak to trying to partner together to grow the elective volume at Sonoma Valley Hospital, and making sure there's an awareness beyond Sonoma County that we are partners and we're able to provide quite a high level of service at Sonoma Valley Hospital. So the catchment area could probably go up through Napa, although the Napa folks would probably cringe at that statement since they have Queen of the Valley. But I know that you draw a lot of folks from Santa Rosa and some other catchment areas. So that's really what that statement is, and it also provides access to folks that maybe live in Marin as well. So seeking all opportunities to try to broaden the scope. Does that answer the question?
It looks
You
frozen.
know, what these questions allow risk as a board? What does that mean?
Bill, can you repeat the question?
The last bullet.
Mhm.
I think that as we collaborate moving
What does it
forward,
mean in terms of which risk mitigation mean to you?
risk mitigation means to me that we are going to continue to be transparent on the projects that make sense and the growth that makes sense for both entities.
All right.
Can I ask a question?
Yeah.
Jen, I've heard you refer to Parnassus several times. So is there a reason why you're just saying Parnassus and not Parnassus, Mission Bay, Mount Zion, other San Francisco parts of the UCSF network?
The reason why I'm indicating Parnassus is because we really are working with Parnassus in terms of tertiary and quaternary care and the opportunities there. That's really where all that care is delivered. Mission Bay is very focused in on cancer care, as you know, and pediatric care. And so they're very specialized in those areas. And really for the adult population, we're taking a look at all of the service lines that run through the Parnassus campus. And it's, you know, it's a rather large institution, but we're seeking, you know, alternatives beyond the four walls of Parnassus because of capacity issues. They're full all the time. So really it becomes incumbent upon us to take a look at other opportunities and other locations to provide care because it's awfully hard to navigate and rather cumbersome to transfer a patient to Parnassus. It just is. And, you know, really in terms of trying to indicate about the transfer center endeavor to improve that process, we're really working very hard with the team and with the department chairs to try to make that process way easier and to eliminate 10 of the steps that it takes to get a patient in the door. So we expect to expand, you know, those improvements as we move along.
And can I ask another question? Can I ask another question? And I'm going to apologize in advance because it's possible that many board members, of which I'm a new one, and you and Shelby and many others that maybe have had discussions for years, and maybe this has come up and maybe it hasn't. But has there been any conversation about collaboration possibilities for long-term care alternatives?
I believe there's been initial discussion, but I would have to go back and take a look and follow up with you after the
not
meeting.
nursing home, but I'm talking about, you know.
Are you talking about SNFs or?
Not SNFs, alternatives to SNFs.
Okay. I think that topic has probably been brought up, but I'm not certain where it stands at this point in time. So I'd have to go back and take a look at that and get back with you.
I mean, I'm not sure if it's something worth exploring, diving into or not. Understanding a lot of very deep challenges, but
sure.
You know, but the population in this community, with the age demographic.
Sure.
So, just a question.
Okay. Are you being specific to rehabilitation, or to skilled nursing, or to just long-term at-home care?
Long-term alternatives to skilled nursing, community-based, long-term care options, alternatives, you know, just, you know.
I think from some of the conversations that I've had, just in general, I think we're interested in an opportunity to take a look at more home-based care options for folks, whether that's hospice, whether that's long-term care, whether that's, we're looking into some of those opportunities, but I'm not sure where we are in the process right now, if it was just a conversation or if we're going to move forward on any of that, but I'll find out.
Because I think there are lots of conversations to be had.
Certainly.
And, once again, with the demographic in this community.
Sure.
So, okay, thanks.
Absolutely.
Jan, I've got a question about our cancer patients here and as to whether a cancer infusion center here at Sonoma would be worthwhile. The trip down to Mission Bay, I've done it myself a couple of times, is a long way to go. The question is that particular service, can that be transferred to a certain degree here in our community? I'm thinking about an infusion center or something that's given at Mission Bay that maybe we can transfer here.
We certainly could take a look at that. We certainly could. I work with Jeff Wolf, who you may know. He is our chief of cancer services, and he is always looking at different opportunities to provide cancer care in the community. I think most recently we've opened up some cancer services in Berkeley, and are going to continue to expand into the San Mateo, your old stomping grounds, as well. So certainly I can bring that up with Jeff and see what the opportunities are.
The reason I brought that up is because I know that you've expanded to San Mateo. I've talked to some of the people down there as well. So I thought, well, that'd be great. Sure. They can someone do the same sort of thing.
Sure.
So as we get into some of these specific opportunities, maybe this is the time to sort of segue to the framework, which is our joint first attempt at laying out what some of the areas for specific exploration are. Does that make sense, Jen, to you and Sabrina?
Absolutely.
And guys, you can come back and ask questions. I think Jen's going to stick with us for a few minutes. But what Sabrina and Ken and Kelly, in fact, and I and Jane Hirsch began to do towards the end of last year was begin to think a little bit about how this affiliation might translate into a set of goals and then thereafter metrics and specific deliverables and the development of a very specific plan against this affiliation, which has big dreams, but not as many concrete steps in it. And so what's on page 6 in the deck, and maybe you can share that, is the first iteration of that framework, which begins to lay out both, the vision for where these two entities might meet and some of the specific areas for enhancing the collaboration. And because this gets a little bit into some of the service areas, I'm going to ask Sabrina to walk everybody through it. And this is the first time the board has seen this as a whole. Jen and Shelby and their team have weighed in on this very draft proposal as it is now. But I wanted to get the board's both input feedback as we look at it. So maybe Sabrina, you can walk us through it and
Sure.
Then get some feedback and discussion.
I am just making it a little bigger.
Okay. There we go. So you guys can see what I'm talking about. So you'll see at the top part that when you look at the affiliation goals, these are really mirror what you just heard from Jen, really focusing on getting UCSF quality care, but at home and within 20 miles of wherever you are, especially in the North Bay, is UCSF. And on the flip side, that coordinates with increasing convenient local access to that quality care for Sonoma. So you can see how there's a lot of synergy because we each have goals, and we're finding where the synergy is between the two organizations. So that's really what you see in the top part. The second part is really recognizing that we're part of affiliates network and looking at our specific geography and the natural relationships that result there for patient care. We're also fortunate that within that, we now have Sonoma really size-wise and service line-wise, catchment-wise, everything is more of a primary care-based hospital. It can offer extraordinary ancillary services, outpatient. We don't have the footprint as have to do the tertiary quaternary care that you'll see at UCSF. And if you've heard, they have a lot of capacity issues. So they're looking to offload some of their lower acuity things to Sonoma, and that hopefully will make patients feel better and do better because they're at home, and it creates space and access for when the patients from Sonoma really need that level of care, that there'll be a spot for them at UCSF. So these are the gives and takes that we're trying to really collaborate on. And in the middle, you'll see Marin Health. And that's the part that we're still developing here, is the synergy too between the three organizations that are very much part of the affiliates network, and recognizing that Marin is that hospital that fits in between. They're not near as big as UCSF. They're only academic affiliation is UCSF, but they're a lot bigger than Sonoma Valley Hospital. And we already have a lot of synergy with Marin Health, and we want to further that and really create a roadmap that's inclusive with the three organizations. As many of you know, Marin Health and Sonoma Valley Hospital have a long history of sharing physicians. We share anesthesiologists, pathologists, radiologists, a lot of independent docs. So there's already a big framework there between the two, and we want to take that to the next level as part of this affiliates network. So the third part, if you'll scroll down there, thank you, is the goal buckets for Sonoma Valley Hospital. So this is specific to, Sonoma's role in affiliation with UCSF, and we want to try to start measuring these. So these, we kind of created individual lines that our next job is to start to quantify. And so once we launch our new joint operating committee, this will be a subject of how and where we can actually put numbers to these buckets so that we can hopefully create a dashboard to monitor our progress and kind of keep us on target. And then we hopefully will be able to do things like assess patient touches. And know by that we mean, how did somebody hit our network and where, and how does this fit into our strategic goals so that we can define those and align them better. So some of these buckets we developed are looking at the surgical facilities utilization. Again, UCSF has a footprint issue as far as capacity. Sonoma has capacity. The UCSF has been in the process of, and we were included in this, of basically assessing all of their OR availability, and not just for their campuses, but we also participated and showed what we have, so they can do a master analysis and look then not only at who has space, but also about what's needed for an operation. We may not have the equipment or the needs that a neurosurgery would ever make sense at Sonoma Valley Hospital, but an endocrine surgery probably could fit nicely. So we're trying to match those things up and really distribute services and bring the ones that can be done well in the community to the community, and take and create space at UCSF for the ones that really need to be there at the same time. So with that in mind and that background, trying to bring a couple new surgical programs where we talked about bariatrics expanding, although Sonoma has that, there's a lot of room to go to the next level with that, and hopefully some synergy with UCSF. We've talked a lot and continue to work with UCSF. I did again this week on GI coverage and long-term projects related to that. And that is actually very well aligned with bariatrics, because there's a lot of preliminary work that relies on GI for successful bariatric programs. We also think that there may be opportunities in some of these other service lines that have been listed here as far as elective orthopedics. Breast cancer serves well to outpatient or to a smaller center treatment like we have in many cases. General surgery, we know that we could probably expand that further as far as service lines. Ophthalmology, pain management, endocrine, gynecology. So we want to do more of the things that we know can be done well at a hospital our size, and work with UCSF to further those cares. And that's what you'll see as you look at these other things too, that theme of doing the right thing at the right place at the right time. So we also want to see that as far as across ancillary services lines, and determine amount that we want to see an increase in utilization. This pairs nicely with the outpatient diagnostic center. So we want to start to measure when we open here what our baseline is and what growth we see, and with those touches, how much of that growth we can attribute to our affiliation and our working together to serve patients, so that they're not going into the city to get their workup. If they live in Sonoma, they can get it here, but yet it can be ordered by their UCSF based physician, and still they can also receive the results. So that's a lot of the work that you'll see in the ancillary services along that. Increasing specialist access, this is similar to the first bucket, but could be more on a telemedicine or outpatient basis. The ones you see here are more medicine-based, less procedural-based, except for GI, which does both. And so that's what you see in that bucket. And those are the ones that I think after COVID, it will stay that telehealth is what people prefer for the basic stuff. Only if they need to be touched or there's something that's going to benefit more than a discussion. And looking at labs, a lot of people would prefer to be able to have that visit from the comfort of their home and saves themselves the drive. So we'll be looking at those best strategies for to increase access to care. We realize in order to do all this, we need to share resources, and cost is always a factor there. So we are already, and we have to find good things that come out of bad situations. And definitely that's how I'm trying to view the cyber attack and the recovery process we've gone through. That is, it's been another example, just like COVID helped further our affiliation, of sharing resources and really learning and helping one another. And UCSF has been amazing. And now we're looking at more specifically how we can, with IT contracts, and how we can expand their service, how we can get shared contracts for some of the security services we're going to need, how we can partner in those ways to really consolidate, to align, and to share costs, and at the same time increase communication by having shared resources. And we can do that also in marketing, in public relations, efficiency lines. We can do that in quality metrics, which we've done a bit in the past. And I think now there's room. I'm already excited that now that I have my official UCSF ID and email, I can start to get into some of these dashboards myself and spend time looking at them and seeing how I can mirror that for Sonoma Valley Hospital. So those are the things that we're excited to get going. I've already talked a bit about the IT integration. There's some more specifics there. We've talked a lot about actively looking about how we can get Epic to our area. Also other telehealth platforms right now. I mean, Epic does have some, so if we go that route, that'll be more clear. If we don't, we've been looking at other partnerships. And as Jen has been talking about, a network transfer center to really look at, as she explained, not only transferring is something Sonoma Valley Hospital does a lot of. We hope that over time, we may be able to, with the correct supportive services, keep more of those patients at home. And this is one of the things that would allow that, is developing that type of support system. And if they do need to go, hopefully this would help place patients in the right place sooner. Right now, it's a pretty chaotic process of just getting on the phone and waiting and seeing who's got a bed and circling around. If we could have a platform that we could see that instead of calling and asking and waiting, that alone would help us a lot in figuring out the best place for a patient for a given issue at a given time, and help within the network that's already connected. All of that, we hope, will improve access to UCSF care. So we're looking more broadly at growth solutions then, so not just having the service lines exist, but the overall growth. And with this, we think that a lot of this needs to organize our physicians. Dr. Minardi asked about how we can get Epic to them. Our physicians are largely independent, and we're not asking anybody to give up their independence, but we are going to have to group together to some degree if we want to look at common solutions such as Epic. And so having a strong physician group to recruit to and to deploy such solutions is going to be an important initiative to collaborate on going forward. And some of those other specialty lines that we think we can do that far is access to care, are a women's health service line. We think there's opportunities possibly in cardiology, definitely in cancer screening is what you would see more locally at Sonoma, with the tertiary quaternary part of active disease management still being somewhat based in the city. But like you said, we are always interested in opportunities to deliver a portion of that care if we can do so safely here in Sonoma. And then of course, virtual care we've spoken about. So that's the kind of framework. And as I said, the next step is to really put numbers to this so that we can track it on a more precise manner going forward.
Jen, do you want to say anything before I open it up for questions? Add anything to that?
I think Dr. Kidd absolutely outlined the growth in our relationship, and really spoke to some of the more detailed projects and endeavors we'll be working on into the future. So thank you for that. I think it encapsulates the relationship, and we're really very excited about partnering into the future.
Any questions?
I'd just like to ask about the first bucket, a little bit about the third as well, I guess. That if we want to add 2 new surgical programs, how do we prioritize among that list? Which ones are we going to target some and go after them, or see what's growing naturally, or what's the plan?
So that's what the next step is really. We'll be having new joint operating committee meetings, and those will be from the team that Jen outlined at UCSF, of her and Ted and Shelby, and then myself and Ken and our new CEO. And there may be other people that join us from time to time, but that is a group that's going to help figure out how we prioritize that. And I think it will be based on several factors. It will be somewhat of an analysis of need. There'll be a doability analysis in there, and making, and then that's largely where we go from. So it's first identifying where the most need is, because obviously we don't want to duplicate something we already have, and the opportunity for expansion and growth and success. So I think it's going to be putting our heads together to figure out that, and that will be the priority will come more naturally from that.
Thanks.
Did you have a question about the third bucket, Judy?
No, it's just the same kind of thing.
Oh, same kind of thing, great. And
Similarly,
by the way,
it's who's got the room to do it at the right time. So a lot of people think that's a great vision for some time. So who's got that vision for a year from now versus 3 years from now versus 10 years from now, that we can, and has the right people in place, will determine a lot of this.
Right. And this initial goal, right, of 2 new surgical programs, there isn't a specific time frame around that. And obviously, if you're thinking about the 10 or 20 years, it would be much larger number, we would hope, to be working on. But it was something in the nearest term that would be a good goal to get to. In fact, a great goal across all the way. And obviously, it hasn't all been filled out either, as you can see. Any other comments or questions from the board before I ask anybody in the public? Any comments from folks in the public? I can't see everybody, so you probably need to speak up. Okay. Jen, first of all, thank you so much for coming and introducing yourself to us. I'm sure we're going to see a lot more of you going forward. I really appreciate both the breadth, the depth, and the collaborative spirit that have come from Shelby and your team. And we are so excited about working together, being part of the UCSF family, and the opportunities for our community, for our hospital, and for our staff to grow. So thank you. And thank you, Sabrina, for taking us through that.
Thank you very much for having me. It's been my pleasure to be with you tonight.
Thanks, Jen.
You're welcome to stay. I'm not asking you to leave, but you are welcome to. But I know Mike is anxious to get started. Mike is here for one of his first of 2 visits to the board that we arranged for as part of the agreement with Valley of the Moon Post Acute Care. He'll come again mid-year, I think June or July, I forget exactly which month, and give us an update on how things are going in the skilled nursing facility after what I'm sure has been a very chaotic last 9 months, which it has been in all congregate care facilities. So Mike, why don't you take it away, and thanks again for coming and joining us tonight.
Well, thank you for having me, and really appreciate you having me tonight and giving me an opportunity to talk to you guys about what's going on in skilled nursing. And I enjoyed listening to Jen and Dr. Kidd talk about the opportunities at the hospital, and all the things that are happening are exciting, and there's a lot of potential there for growth and opportunity in the community. And we're excited to be somewhat attached while all of this growth and opportunity is happening here. So if there's anything in any way that we can be supportive of that, we're all in, and we're cheering for the partnership. So I always enjoy coming to the board meetings. The first board meeting I came to was before our partnership began, and we were talking about the potential of outsourcing or having someone come in and manage skilled nursing. And I think you guys do a wonderful job, and it's a big job what you do, and so it's much appreciated. It has been a really interesting time, even since the last time we met in the summer. With the year being over now, we have really had the opportunity to see a lot of progress. We're excited that on the 30th of December, we got the first round of the vaccines into our facility, and on the 20th, we'll get the second round of the vaccines into our facility. So it's exciting to hopefully see a little bit of progress in the way that we battle COVID-19. But in the meantime, for the last 9 months, what was an emergency in March is now sort of normal today. And the way that we deal with it and the way that we've asked our staff now to approach this new year is that this is where we are, and we know how to work in this environment, and we want to continue to focus on things that help us grow and do a better job with quality as we continue to deal with COVID, and not just have the emergency be what dominates the day. So I'm going to give you guys some numbers and go through things and give some time for some questions, and I'll be pretty fast with the numbers. So if you have a question, please don't hesitate to speak up. For our quarter 4 average for our daily census, we were at 21.3, which is down from February. And we noticed this trend predominantly in the second half of the year. We had about 62 admissions in the first half of the year. And in the second half of the year, quarters 3 and 4, we only had 14 admissions. A lot of reasons for that. But in the first half of the year, we didn't have any issues where we had any exposures or where we had any COVID positive in the facility. So we were just operating normally. In July, the only COVID positive that's been in Valley of the Moon post-acute was in July, and it was a resident that was exposed upstairs. Nobody upstairs knew. It was nobody's fault, but we know this is how things happen. And when we did a COVID test upon admission, the resident tested positive, and then the resident transferred out, I believe, back to the hospital. So they were with us for a couple of days, but we're very fortunate that in 2020, that was the only COVID positive that we had in our facility. We have had probably the same as the hospital and every other healthcare facility, we have had staff who have tested positive. And then the goal is that when you have a staff test positive, you go into precautions, infection control precautions. And those precautions include you stop admitting. And so that's why in the second half of the year, we've had multiple times where we might feel like a staff has tested positive. We might feel like there's potential exposure in our facility. So we stop admitting for 2 weeks. We test all the staff and all the residents for 2 weeks and make sure that we're clear. This is pretty common practice in all skilled nursing facilities right now. And we're just really grateful that each time we've gone through that, knock on wood, everyone's been clear. And it's really difficult for any place to keep staff 100% free and clear of COVID-19 because they live in the community. I myself had my turn to have COVID-19 in November. It's in our community. It's where we live. We go to our facility, which is locked down and has infection control procedures. And the goal is that if somebody on a staff is positive, that it's not transmitted into the facility. And at Broadway Villa and at Valley of the Moon, we've done a very good job with that. But we're especially proud that at Valley of the Moon, we've been able to protect those residents that are there. We have had a low census because of the different shutdowns, but I would rather have a low census than have an outbreak. And so it's been very good, and we're excited now to have the vaccine in there. Our average occupancy in Q4 was 78.8%, which is down from 91.98% in the first quarter. And our Q4 census was 65% long-term care, and that's really helped us hold our overall census number. Is the fact that we carry about 15 long-term care residents in the facility. Like I said before, we had 14 admissions in Q4 and 16 discharges. Our average length of stay is 18.4 days in Q4, and that's for a skilled resident, obviously not for long-term. So that would be like a Medicare length of stay. But that's decreased from 21.76 days in the first quarter. Our average 30-day readmission rate is actually really good. For quarter 3 and quarter 4, it was 6%. The number of residents positive for COVID in 2020, I explained that earlier. We had 1, and we had 0 deaths related to COVID. Can we go to the next slide? I just put this census detail in here. I just kind of went through that a little bit. We talked about the difference in admissions and how that's affected overall census. And you know, if your census is down, so your revenue is also affected. I'll talk about that when we get to the revenue slide. But there were adjustments that were made with CMS and with the federal government to provide help for skilled nursing facilities in this time. The board would know Ensign decided not to use any CARES Act funds, and we returned those to the hospital. Other skilled nursing facilities have used those funds, but we felt like we didn't need those, and there were some strings attached to having that money and using that money. And our company is very strong, and we didn't feel like we needed to potentially be in any situation where we looked like we were receiving help that we didn't deserve. So we gave that back to the hospital. But the programs we did take advantage of is the CMS put in place a skilled in place exemption so that we can have admissions come straight from home without a 3-day qualifying stay in order to avoid potential exposure by having to go to any hospital and be in the ER or in a hospital. Which helped us take admissions directly from home, and our local doctors here in Sonoma were really educated about that and supportive of that. So the admissions we did take, multiple of those came straight from home. The other thing that they did is anytime you have to shut your facility down from admitting because of exposure, you can bill the rate for the long-term care residents who are on precautions for potential exposure. They become a skilled rate with CMS. So they're not a long-term rate, which is lower. We can bill that at a skilled rate, which is higher. And so that helped offset some of the financial losses of having lower census that we billed at a higher rate whenever we were shut down. For any resident who could have potentially been exposed. So for example, if we had a CNA who tested positive and they worked with 3 rooms and there's 2 people in each room, then we could skill those 6 people for exposure, and Medicare would take over instead of Medi-Cal. And that's been a really nice adjustment by CMS to help our facilities stay solvent when our expenses are so high with PPE and weekly testing of staff and residents and everything else that's required of us at this time. So next slide. The quality measures that we talk about when I come, I'm going to insert a few changes as I talk because I needed to submit these slides to Vivian in December, and the 4th quarter wasn't over yet, so our statistics weren't complete, but I have the complete statistics as of today, so I'll clarify a couple of things on here. The first one, we do a survey on the exit and try to assess overall satisfaction. When we talked about this dashboard, when we took the facility over in 2019, we felt like the metric that was most important as we worked with Mark Kobe and we worked through this dashboard was whether or not people would return if they had a need again, or if they would refer their friends to Valley of the Moon. And we were at 100% for quarter 4 with discharges. We didn't have a ton of discharges, but fortunately the ones that discharged was 100% positive. As far as falls, we had 3 falls in 1,960 patient days. 2 of those was the same gentleman, and 1 was someone who isn't in our facility anymore. But I think the important thing to note is that some of the long-term care residents that we have, they are declining. They are sick. That's why they're with us, and some are declining. And if somebody has, let's say, something that would impair them over time as they get older, or the longer they have that condition, sometimes probably I'm going to be the same way. They're a little bit stubborn about wanting to still get up and do things and be independent. And so sometimes those falls happen, but we do a lot to mitigate that and really watch the people who are at risk. Restraint-free environment, we have 0 restraints. It's that we don't do that in our facilities. Pressure ulcer prevention. This is one where on the slide that you're looking at, my MDS coordinator came to me today with horror in her eyes and a red face and very upset because she realized she had transposed the numbers. When she came to bring me the current end of Q4 numbers, she realized that she had accidentally put the long-term number and the short-term number, and she had transposed them. So the current numbers on that is short-term, we have 0% pressure ulcers. Long-term, we have 2.13%.
Mike, could you explain why you have 2 different metrics for pressure ulcers?
Yeah, the program, the service that we use is called Simple LTC. It's used widely here in Northern California to measure statistics for long-term care and for skilled nursing facilities. And they break it out for us with a long-term and a short-term.
So this relates to the patient being short-term or long-term?
Correct.
I see.
Correct.
That's what I was asking.
And so with the numbers on the slide you're looking at being transposed, it almost doesn't make sense that a short-term patient would get a pressure ulcer and a long-term patient wouldn't. And it was Mark Kobe called me the other morning and he's like, "Are you sure this isn't backwards?" And so I asked my MDS nurse to check it. But a lot of times you're going to have a different percentage of risk of pressure ulcers if somebody is a long-term resident, just because of the way it is.
Mike,
Yes, ma'am.
how do you define long-term versus short-term? What's your cutoff?
So we're generally going to use long-term and short-term based on the payer source. So if someone has a custodial payer source like Medicaid, Medi-Cal, or partnership, those are custodial payer sources. So we're getting paid a long-term rate for them, which means they're going to be with us for 90 days, 120 days, 5 years. They're going to be with us for a long time. If somebody's with us and they're a Medicare or an HMO and they have a solid discharge plan and they're there, let's say they break their hip, they come in, they get physical therapy and occupational therapy, and then they're discharging within the 100-day window of Medicare payments, then we'll classify those as short-term. Does that make sense?
Yes, thank you.
Okay. So,
Can I ask a question about that?
Yeah.
What is the number of long-term residents that you started with in this, when you took over at Sonoma Valley Hospital? What's the number of long-term residents that you started with, and what's the number you have now?
It's a good question. When we took over the facility, the focus was on skilled short-term, and they had a census of about 9 or 10, and they had, obviously that would leave 17 beds empty. We have now, in our facility right now, we have 15 long-term, which gives us 12 beds for skilled services. And the difference in a lot of the metrics, if you were to compare, for example, 2020 versus 2017, you wouldn't see any of the quality metrics registering any kind of number for that facility because there just wasn't any long-term residents. And so as soon as we start to have a long-term resident, you'll see something like number 5, where you have some antipsychotic medication, many times just because of what the doctor has prescribed for someone who's got conditions that are declining, and they may have behaviors or they may have a need for antipsychotics. You'll see those numbers generally go up the more long-term residents that you have. And I think that's why we kind of break out the difference between long-term and short-term. We wouldn't want to mix the long-term number of days for length of stay with the short-term days for length of stay, because it would make it look like everybody comes and stays at the facility for 6 months, and they don't. And we want for the state and our hospital partners and everyone else to know what the performance is in each of those categories. The antipsychotics, I think, is a concern for us, and it's a concern everywhere in California. Obviously, we don't prescribe those meds. Our medical directors don't prescribe those unless it's an extreme situation. But when people come to us and they have orders for those meds, we provide that, and then we try to have our medical director work with the primary care physician or the doctor that prescribed those antipsychotics to gradually discharge those, and we try to not have those in our facility as much as possible. In fact, a lot of times with certain conditions, if they're on those meds because they have terrible behaviors and they're on pretty high doses of meds, we may not admit those into our tiny facility, because small problems in a really tiny space can be really big problems, and it can affect everyone's quality of their stay and their recovery. So we're really careful and partial about that. We do have a great number of the, for number 6, the number at the end of Q4 is different than what's on your slide, is 86.98% successfully discharged and returned to home.
Okay, so Mike, one more question. These last 3, these are all for just skilled? Well, actually, no. So this one is just for skilled.
This is anyone who we would successfully discharge. So this could be maybe we've had somebody for a long time who's finally able to discharge home.
To go home, even though it's a CMS report.
Mm-hmm.
Okay.
Yeah, because they'll be, yeah.
No problem.
So if 81% are discharged, then wouldn't that imply that 20% are long-term?
No, a successful discharge means that someone has they've got a safe place to go, and they can successfully be discharged home to a lower level of care or to home health, or possibly even a hospice, but they have been successfully discharged back to the community.
No, but in terms of the overall residents in the facility, if 81% have been discharged, then 19% have not been discharged. Is that correct?
Yeah.
So that means, does that mean that 19% are long-term?
No, you didn't discharge 81% of your clients.
We're not yeah, I mean, I don't know how to answer that question.
Mike, I think what we're saying is that of the patients that were discharged,
right,
81% went home.
Correct.
Oh, because some may have died and some.
Yeah.
I see.
Correct.
Of the patients that were discharged.
Yeah.
I'm sorry. I'm a little slow on the uptake, I guess.
Thank you.
Next slide. So one of the big measures that we use is the re-hospitalization rate within 30 days of a discharge. So, and this probably plays into the previous stat you know, the previous question that we answered on the dashboard. And that is, you know, the state will really review if we have somebody that we discharge too fast and then they're readmitted to the hospital within 30 days. So this 9.15% is a very good rate. This is a Q4 number. The number I gave you before had Q3 and Q4 in there. And so that is 9.15% for the Q4. The residents who report pain, this I always feel like I need to explain this, but just the way the state really doesn't use this anymore. It's a question on the dashboard that we put together with the hospital, but the state doesn't really use this anymore because everyone has such a different reaction to pain and how they measure their own pain. But the key to this for the quality measures for CMS is, are we doing everything we can to manage the pain? So that one's kind of hard for me to explain through because we don't really use that statistic anymore. Discharged residents with an emergency room visit with 30 days, 8.1%. And then we don't have very many catheters downstairs this year, and our result for urinary tract infections is 0. PICC line, central line infections is 0, and no C. diff in the facility. So I'm happy to answer any questions about those quality metrics on that dashboard.
I just want to ask one more thing about the antipsychotics, because that is a little disturbing, as you indicated. But is dementia one reason that these people come in on antipsychotics?
They come in, there's different reasons. It's usually it's, yeah, it could be dementia. It's usually something that might have to do with behaviors. If somebody's, if they're dangerous to themselves, if they have behaviors where they could be dangerous to others, if they have behaviors that would cause them to, you know, maybe act differently than they would if they had their capacity, that's usually where a doctor has decided to medicate them rather than treat them any other way. And unfortunately, a lot of times, just wherever somebody comes from, a doctor's decided that's the first course of action. One of the things that CDPH especially goes through when they review us is, have we made an effort every year to reduce the amounts of antipsychotics that are being used in our facility? And have we worked with our medical director to try to reduce that?
Yeah.
Because it's a chemical restraint, and we're a restraint-free facility.
Absolutely.
And so there's a great effort that's made on our part to have our medical director work with whoever the prescribing physician is. But then there's some where it's really indicated and it's needed for their situation. So I'm glad there's clinical people that have a great concern for these residents and can help make those good decisions. But we really try to push for that.
Thanks.
The last slide just kind of goes through and outlines what the finances look like for the second half of the year. We got a little surprised. When I reported at the middle of the year, we had a month where we had a revenue adjustment because of a contract discrepancy that really gave us a poor month, and we felt really bad about it for the month of May. 2 days later, Santa Claus came early, and we received notice that the discrepancy was wrong and things were corrected. And so the money was given back to us in July, which makes July look really, really good, just as much as it made May look really, really bad. But that evened out between the 2 months. And so we ended up on the year showing a decline in revenue, but not as bad as we would have experienced if we had just had to live off of the census that we had alone, because we did have a real decrease in admissions, but because of the skill in place exemptions and the exposure exemptions from CMS, it helped offset some of the loss of revenue that we would have experienced with the low census.
Mike, may I make a comment here about
Yes, sir.
the hospital side of the financials, which is not reflected? We just finished our Medicare cost report in November, and for the last fiscal year, if we remember, prior to your takeover, the hospital was losing upwards of $400,000+ a year in terms of operating skilled nursing. So we've not only saved this service for the community, but last year, the services we provided from a hospital standpoint to Valley O'Noon cost us with overhead about $684,000. They paid us back $669,000, so we had a net loss of about $15,000. However, with the CARES money, we got another $250,000. So we had a little bit of a gain there. And to pick up on the $15,000 effective July, they've agreed, Ensign's agreed to increase rates. So we'll probably end up with a break even this coming year, including the profit sharing. So all in all, I think it was a successful, both from a clinical standpoint and a financial standpoint, a successful arrangement we have with Ensign.
Thanks, Ken. That's great. Mike, before, just a quick question before for others. When we first started this, discussion with you guys and in the original contract, you guys were heading towards being a subacute unit. And I know there were licensing issues that were going to take at least a year. Can you give us an update on where you are with the licensing and whether that's still the plan and what that'll do to the financials going forward, if it is?
Yes, I appreciate the question. It's complicated at this point because it was the Department of Public Health. Everything just kind of got frozen this year. There's literally not been anything done on either side with this since January. So I think that as soon as it's appropriate, we want to pick that back up and kind of look at the feasibility of it again. I will say we're operating very well as a skilled nursing facility. We had great relationship with CDPH this year. The surveys they came in to do with infection control were outstanding. We're providing a really good service to a lot of people in the community, and the partnership that we have with the hospital is outstanding. I'm concerned now that I've been driving this ship for 2 years or for a year and a half. My concern is that we really make sure that it's financially the right thing to do to go to that acuity level when we're already performing and we have beds available for the community for exactly the types of things that Jen was talking about earlier, with the services and the partnerships and the things that could be coming into the community. That'll increase the need for skilled nursing. And if we become a subacute and tie up all those beds with subacute patients who could be there for potentially years at a time, we may not have the ability to provide the service at the same level. And so I think that that's something that it's still on the table. It's very appealing. It has what appears to be a really good financial upside. We have sister facilities that operate subacutes in California, so we have plenty of models to study and see if it's the right thing. But at this time, it's just all pencils are down while we get through this COVID situation and then see what the new normal will look like maybe when the vaccines are out and things can hopefully settle down a little bit.
That's great. Other questions?
Yes, Mike, what's your protocol for a resident who tests positive for COVID, but he's asymptomatic, he or she is asymptomatic in your facility? Do you have to transfer them because they're positive? Can you isolate the resident there?
Yeah, so it's a great question. The answer is the same for every skilled nursing facility. The CMS has done a great job, CDPH, I'm sorry, has done a great job of rolling out what the guidance and requirements are for mitigation plans if in fact you have somebody test positive. There's things you do with residents, there's things you do for staff. If we had a positive resident, we have prepared 2 of the rooms in our facility. We have a temporary wall that maintenance put up for us. It's beautiful. It has a door in it and everything like that, but it walls off one end of one wing of the facility. And those 2 rooms are isolated completely from the rest of the facility. So if we had a positive test, we would just move the resident into that isolated area, and they go on all the protocols for observation to make sure that we're monitoring their condition. They have dedicated staff that would be in that area with them, full PPE, a separate entrance and exit, a bathroom that's there for the staff to use, so that the staff don't work in that area and then come work in what we would call the green area. And they require that we separate our facility into a green zone, a yellow zone, and a red zone. And the red zone is a red zone if you have a COVID positive in it. And so the rest of the time we'll use it as a normal room, but if we had someone test COVID positive, we would arrange the rooms and put them back into isolation and isolate our staff as well, so that we try to mitigate the chance of it spreading from one person to another.
If they become symptomatic, are they automatically transferred, or do you treat them there?
We treat them here. If we had more positive symptomatic or positive residents than we could handle in our small space with isolation, we would use our COVID unit that we've established at Broadway Villa, and we would transfer them over there. Broadway Villa, we've kept our COVID. We don't have an outbreak anymore since September, but we kept the COVID unit open. We take admissions from Sonoma Valley Hospital that are COVID positive. It's separate as well. It's a red zone. But right now, if somebody doesn't have a medical condition that's greater than we can handle, we'll keep them there and treat them and help them recover. If they had shortness of breath and they were losing their O2 sat was down below 95%, our medical director might ask that we transfer them to the hospital. But other than that, we'll just treat them where they are, and we'll take good care of them and help them recover.
Okay, thanks.
Any other questions for Mike? Public? Mike, thank you again. Really appreciate
Thanks for having me.
Appreciate the partnership, appreciate the service you're providing for the community, and help that you've given to the hospital in terms of our own financial situation. And look forward to seeing you again mid-year.
Thank you.
Thank you.
Great. So number 8 is the board committee assignments. As you all know, every year we actually renominate board members to serve on various committees. Typically we have 2 board members per committee. One typically acts as the chair. Another one is a member of the committee. This year we have an additional committee to staff, the Ucsf Sonoma Valley Hospital Affiliation Oversight Committee. I don't think Jen spent a lot of time on this in her presentation, but part of the affiliation agreement established 2 levels of integration work. One was at the board level, and one was at the more operating level, CEO, CMO level. And so the one that is obviously the board committee is this Affiliation Oversight Committee. And in the terms of the affiliation agreement, the board chair serves on this, and one other board member to be appointed by the board chair. And so for that position, I am nominating Judy Bjorndal to become part of that committee along with me. And that committee will meet, could be quarterly, could be twice a year. We haven't yet established that. But we will also use that affiliation framework, or the evolution of that affiliation framework, as the guide for our work as we oversee and negotiate and help to direct the affiliation progress. obviously that's not a decision-making committee, but it is a recommendation committee that will come back to the board and obviously back to UCSF for that. If you guys don't mind, I'll go through all the committees and nominate a slate for approval. For quality, Dr. Minardi has agreed to take on the chair role for the quality committee, which I'm very happy for. And Susan would continue to be the board member on that committee. These are two people who have spent many years on this committee, and their continuity and their obviously deep experience are incredibly appreciated and I think needed there. For finance, I'm going to ask Bill to become the chair of the finance committee, along with me as the board member there. Bill hasn't been involved in finance for several years, but obviously had been in the past. So I expect he'll come up to speed rather quickly, and has a lot of experience in that area, being a former banker. And for governance, I'm going to ask Bill to continue in his role as chair of the governance committee, which hopefully is a lighter duty committee than some of these others, and ask Judy to join him on that committee so that we have, again, some longer term continuity and expertise with new board members spread around. Those are the 4 committees and my recommendations and nominations for those to serve. Look for a motion and a second, and then take any comments.
So moved.
I'll second.
Any comments, changes? Great. All in favor?
Aye.
Aye.
Terrific. Thank you so much. Number 9 on the agenda is reinventing the Chief of Staff report. I'm going to ask Sabrina to help us think about this, but what we're really looking for here is input from, this is the most clinical oriented staff, I think, board that we've had since I've been around. Maybe that wasn't true years and years ago, but as we, get a Chief of Staff report several times a year, I think both Sabrina and the Chief of Staff would like to know what we'd like to know more about. And so very simply, she's going to sort of give us a little bit of prompting, but really to get particularly some of our clinical members of the board thinking about what you'd like to hear from the clinically oriented, from the Chief of Staff when he or she comes to speak to us. So with that, Sabrina, why don't you take us through what you've sort of compiled with Mike, and then open it up for any input.
Vin, can you bring that sheet up, please? To give you guys, I'll just start with, it can be quite confusing, and even in my daily world, sometimes I have to ask myself which hat I'm wearing. When is this medical staff, is this CMO, or is this quality committee, really what goes where? And so I'll start with saying that is a very gray area that sometimes we even have to go consult the bylaws to be sure what falls where in certain instances. That in mind, our Chief of Staff, who is the chief over the medical staff, that is elected by the medical staff for a 2-year term, and they usually come to speak, I believe, twice a year to the board. And it's been noted that those reports are really not standardized, and we were hoping to provide a more standard guidance, not only for them, but also, as Joshua said, know what the board would like to hear from the medical staff. So this is my stab at trying to create that. And the point of this is not just to put this on paper and say, here it is, goodbye, but that this would be the framework for discussion, and to really talk about what's going on. So first off, I highlight just the numbers of the medical staff, because I think that's where you're going to find out if there's gaps or needs, or if somebody's left or there's a new person. And so that's the point of highlighting the numbers, is to see those changes and needs involved. Then I've gone to kind of a quality thing, and this is one of those really gray areas. Most of the quality work for the hospital, and even really the medical staff, ends up coming through your board quality committee, and that a lot of that is going to be reflected there. That being said, there are a few things that we do track that are more specific to physicians, and we use something called Rate My Hospital, or Q Reviews, and this is actually a texting platform that we can use on the outpatient side. We cannot use it on the inpatient side. and it's sent to each patient after an encounter, and there's various questions get. We have found that incredibly meaningful, especially in our emergency department, and we can break it down to the level by physician, and they can talk about the time spent with the physician, they can talk about different things. That's where we get the comments of whether or not the bathroom's clean and everything else you can imagine. So we find that a very useful program, and I think that type of not only looking at the score but the trend, that's a tool we can use, and I'm trying to develop further to really work on quality improvement from that very physician-centric aspect specific to ID. On the inpatient side, we can't use that tool. We're tied to age caps. We're a little more restrictive, and for Sonoma, we find somewhat problematic because of our small numbers. So this is always a challenge to find meaningful data in really tiny numbers. And so then I think it's important to look at the scores, but they can be very difficult to interpret. So again, using those scores to speak about any quality improvement measures or initiatives, to talk about how the physicians are interpreting the human experience initiative that we've done and things like that. That's where you would get that information, is feeding from the HCAP scores, because that's really what drives a lot of those conversations. And then any other initiatives such as the human experience and things like that the medical staff may be involved in, I would encourage them to speak about there. Finally, the medical staff meetings. No, I'm not asking them to copy their minutes. We can't. Those are protected anyhow. However, what I would like to do is, this is where the pertinent departmental staff reports are held. And so I think that by looking at those, chair could maybe highlight some of the themes that have come out of the various departments over the time in between. Bless you.
Thanks. Sorry.
And so that was the idea, is that these are the main medical staff specific, and that they could work with Stacy and grab those minutes and use those to really highlight those departmental specific things that have happened during that time frame. And then just a brief in the end, I would like them to really, from their point of view, summarize how things are in the medical staff. This year we've not been able to rely on data when we haven't had it because of a cyber attack, or just because it's been skewed because of COVID. So I think commenting on those things and how the medical staff is dealing with things like COVID overall, the cyber attack overall, the morale, the needs, the affiliation is an important aspect for you all to hear as well. So that's what would be in the last statement. So that was kind of my stab at what you all might want to hear. So please tell me now what you really want to hear.
Yeah, Sabrina, first of all, let me just say that this is a great idea. Listening to the chief of staff talk over the last couple of years, I have found it less than satisfactory, and I don't think the reports revealed very much. I learned more when I went to the quarterly medical staff meetings and talked to the physicians. And some of the issues that were brought up by the physicians are not brought up during that time. The chairman wouldn't really say much about issues that were there. So I'd like to hear more of the issues that physicians are concerned about. And this would be a great time.
Okay, so maybe I could put a section for like current physician concerns or something like that.
Absolutely.
Okay.
Yeah, I agree with that. I was going to say something very similar, that have space for what do they want to ask of us? This is their opportunity to address the board.
Okay.
Or
maybe we could say their concerns or potential needs. I guess.
Yeah.
Okay.
Or both, concerns and needs.
Mm-hmm.
So another question I have, I just want to clarify that the part about the medical staff quality. Now this report is just going to be on the agenda and there for everybody to see, right?
So these would just be those numbers, and then I would hope that they could speak to those numbers as far as any trends or things that are being done to either congratulate positive trends or deal with negative ones.
Yeah, okay. We just need to make it very clear that this is not for protected.
No, that's why I've chosen just these few here, because it wouldn't be overlap with, one, it wasn't overlap with board quality, and two, these are not more the protected information if we keep them to the general numbers that we publicize in our board report.
Great.
Any other suggestions?
This is Bill. I don't have any other suggestions, but I compliment you on this very good initiative. I like the standardization of a report, because over the years, as different chiefs of staff come on, they give us different kinds of reports. Some of them are very, very brief. So I like the standardization. I like the points that have been developed, especially the quantitative aspect that comes in here, you know, some numbers. So very good effort.
Well, thank you. If there's anything else you think of, send it my way. Otherwise, my goal will be to really, I guess it'll be Dr. Brown's next report. I think that's in February or March, if my memory serves me right, to work with him to bring this together so that we can try it out and see if we can't have a more meaningful conversation.
Great. I echo Bill's comments. Thank you. Quick update on the CEO search. The search committee is in the process of arranging to have 2 candidates come back to Sonoma. It's obviously really challenging in the time of COVID, particularly given, you know, the need for, I think, both candidates to meet people in person and the desire for them to do that, and for people in the community and the staff leadership to meet the candidates, and also for the candidates to see the facility. And obviously it's just not a very easy thing to do for travel reasons and for safety reasons. So we are still in the process of setting those up. We should have two sets of those towards the end of this month, the beginning of February, and the results of those meetings, these are not interviews, obviously there'll be meetings, will be summarized, and then the board will gather to review those and see if there is a candidate that the board would like to move forward with. So that's where we are now. I will tell you a little bit about the you know, the times that when the candidates are here locally, they will meet with each one of the board members. They will meet with, I think, 7 or 8 different members of the community, including a couple of our major donors. They will meet with a couple of leaders, with Steve Aker, who heads the EMT, with Cheryl Johnson, who works at the Community Health Center. And they'll meet with several physicians and also the leadership team of the hospital. And I guess that's not the word, the admin team of the hospital, just to get the right wording, the CEO's direct reports. And so it's quite an extensive program when they're here. And again, that has 3 purposes. One, of course, you know, there's some evaluation that's part of that and feedback that we would ask for, although these are not really interviews outside of the board members. But second, it's obviously the candidates are going to want to know about our community and our hospital. And so I hope everybody will allow them some time to ask questions about that, get to see the caliber of people who we both employ and who we work with in the community and the support that we get. And then obviously we're hoping that people will help convince candidates that are, you know, terrific candidates who will bring back to the community. These are really highly qualified people. Convince them to accept a position with us. And so there's, I won't say it's a sales job, but really hope that people will be putting on their best for these candidates. So that's where we are. Any questions about that now?
Yes. Joshua, yeah, I've got a question about the actual meetings. I assume that they're one-on-one, the candidate with, I wonder if that's a good idea. I have a feeling of parading in one person after another and giving the same story. I wonder if you had 2 or 3 people at a time so they can hear the answers, it would be easier to the candidate. I don't know if you have 20 people parading in there asking somewhat similar questions and he has to repeat himself again and again and again and again.
Yeah. So, you know, the idea, obviously, it would be really nice to have larger group meetings. In these times, that's a very challenging thing to do. Even having one-on-one meetings is not so easy. And so I think after quite a bit of thinking about this, we are going to continue with one-on-one meetings and ask for the perseverance of these candidates. I don't think people will always ask the same questions. And actually, by the way, there are 2 sets of meetings that will be larger groups. The physicians, I think, will meet with the candidate virtually in a group meeting, so in a Zoom meeting, and some of the admin staff will do that in a group meeting.
Okay, that's a good idea.
Yeah. Comments, questions? Great.
I'm just going to say, let's remember that they're interviewing us too. So
that's right. That's absolutely right. We welcome that. Number 11, Sabrina, back up again for the CMO report.
I forgot to hit unmute there for a second. Sorry about that.
I myself for a bathroom run. I'll be back.
Okay. This, I apologize if you are looking at your screen from the packet. I believe there was a copy and paste error. So ignore the old part, and I believe the actual report starts a bit farther down.
Number 4.
Yep, number 4. So I think that there was in putting the packets together, there must have been a copy and paste in the actual report on the screen, and that's mine. Is number 1 is December. So my apologies for whatever happened there. We are talking about December, not March. It has been a long time that we've been doing COVID reports. But before I get on to COVID updates, we also, the highlight of December was significant recovery from the cyber attack. We have officially 100% transitioned this permanently to the leadership of UCSF, and that has just been an amazing experience under Jane Wong, who's their associate CIO, and Dawn Francis, who actually works as part of Bay Health and is under Jane as well. They are really doing an amazing job with these final stages and helping us prepare for the future. And so we're really now focusing on the last details of recovery and planning for ongoing cybersecurity and what we can do to prevent to the best of our ability. Although we know our government can't prevent this type of attack either, we are hoping to be better than them in the future. So that's where the stages are, and a lot of that is what we've been working on in December. Excitingly, I would like to officially report that we did end stroke divert mid-December once we were able to reestablish all of the components that go into the complex program we have around teleneurology and stroke. Largely that was so difficult because it proved that the imaging systems were greatly affected by the cyber attack, and getting those back up all the way to be viewed remotely at the high quality that they could be viewed at the hospital was challenging. Many pieces go into that. So that did occur, and we have been back up to normal, and everybody has the remote access restored and able to do that program safely. We did, as I've said many times, continue to care for stroke patients, but we could not officially meet the requirements to come off the ambulance diversion status until we had the program fully restored. So happy that finally did occur. Otherwise, COVID, it has been all about vaccine preparation. Otherwise, besides the increase in numbers that the community has felt and led to another regional stay-at-home order. Fortunately, our census for the hospital has been an average, I would say, of 3 to 5 inpatients at a given time. We are seeing a lot faster turnover, which is a good sign. That means that people are actually coming in and going home quicker with shorter stays with COVID for the most part. So that is helping. We have learned a lot. We continue with all of the therapies that have been become available now and offering those through Sonoma, including the outpatient monoclonal antibody therapies. We are continuing with those as we still have allocations from the county for those. But to speak a little bit of vaccines, I am very excited to say that I think it's 335 is actually their current total that we have vaccinated. The vast majority of those are our staff and physicians. We've also begun doing outpatient clinics as far as independent physicians and their staff. And we will be doing a 3rd round of the first doses next week and reaching out to additional in-home providers and such hospice providers, other independent practitioners that we have located within our community to hopefully reach close to the end of the phase 1A tier 1, 2, and 3 distribution for this vaccine. For our first 2 distributions, it has been with Pfizer. Our next one we believe will be Moderna, and we will also be starting, actually next week will be the first round of the 2nd dose for those employees that were able to get the dose the very first day that we were able to offer on the 21st and 22nd of December. So that has been a very exciting process. with that, we did some education and outreach to our staff and physicians with a kind of in-house town hall. And then I have one planned for next Tuesday for the broader community. And please encourage all to join us. I'll be talking about the mechanism of action with an mRNA vaccine, about the safety profile, about comparisons of the Moderna and Pfizer, and what our experience with administering it to date, some of the logistics involved, and anything we do know about distribution. So that is where we still have a lot of gray areas, but I will share every bit of knowledge that I've gained up until Tuesday with the public that we have on that information. So that's where we're at with vaccines. Just other quick updates. Thankfully,
quickly about Sabrina.
Yes, please.
When I was talking with Mark the other day, you indicated a number of our staff were declining to get the vaccine. You want to talk about that at all?
So I don't have a final number on that, so I hesitate to dwell too much. I can tell that we've got less than, and these numbers overlap because not all belong to Sonoma Valley Hospital, but we, on last count, had 140 people on our list for this next round. That include people who had declined or just asked to be rescheduled. At this point, we haven't asked people to firmly plant themselves in a no, I'm not taking this bucket. We've given them the opportunity to wait and see how the first round or two went and then sign up for it. And we feel that a lot of people will be captured in this next round. So I don't have a firm number for no, I'm not taking it at this point. We have, like I said, the vast majority of that 100-ish, I would say, are people that either couldn't make it for the day they were assigned, and so they chose to reschedule, or they just were a little nervous and said, I don't want to be the first round, but I probably want to be the next one. And so I think that's where we're going to see. That being said, we will have some declinations, and those will be allowed because this is as long as it's on an EUA, and we will document that and keep doing outreach to those individuals. And then once it likely will become mandatory, the same as the flu vaccine, once it has full FDA approval. So I'll be happy to update you more with those numbers once I make them official. Otherwise, I just want to say that thankfully we N95s and other PPE are in good supply, and we still have PAPRs, so we're being able to do our business safely, and that is, I know, a relief to all involved. Testing is still a struggle. We continue to have a great partnership with UCSF. We have struggled from the beginning with finding supplies for our in-house machine, or finding any in-house machine that we can operate at our level of lab. That's a very narrow market and very competitive, apparently. So currently we are out of in-house cartridges for our PCR machines, so we're relying exclusively on UCSF until we get another shipment, date unknown. And we are also in the process of validating antigen testing and algorithm to fill in for that, where we can use it appropriately to fill in the void. So continue work and continuing whenever we get an obstacle to find a solution with regards to testing. As I mentioned, we are doing I think we've done 2 to 3 a week now, and we're starting to track it better, of the monoclonal antibody outpatient infusions. And we, as I said, we will continue those as long as they're available to us through this mechanism, and then we'll assess at the point when they become available for purchase. GI services continues to be a slow process. I did have additional discussions this week with UCSF, and they would like to relook at this program again from a different lens. So I'm optimistic through our affiliation we will find a partnership, but I don't have a timeline then. They remain very committed to helping us find a solution to this. So that's encouraging, but obviously not the immediate need that we would hope for. ED is about the same. Census and daily average has been around 20 for most of the fall, and that's prior to COVID, our daily census was much closer to 30. So that is steady, but remains depressed. Otherwise, we are continuing to actively interview for a replacement for Janine Clark, who was our OR director and has left us to move out of state. So that is a void we are filling, and we do have some interviews lined up for the near future and hope to find a great replacement for her. Otherwise, I just want to mention that Sonoma Family Practice, which is part of our 1206B clinic, we have officially entered into a management service agreement with Meritage Medical Network, and the purpose of that is to hopefully find the best long-term home for that clinic and to keep them in our community. the hospital took over their management in a way to stabilize and make sure they stayed here as really kind of a temporary move. And now we're looking for partners to take that on in more of a permanent role. And Meritage is very interested in assisting and supporting the physicians through this. So we are now in a shared agreement with them over a management service agreement. And so that's an exciting next step for them. Otherwise, I don't think I have much else to new news, I guess, to say. So happy to take any other questions.
Yes, Sabrina, I have 3. I'll ask one at a time so you don't have to remember.
Thank you.
Will the hospital be offering vaccinations to the general public when the 1A group is completed? Or is CVS going to be the main authorized provider in our community?
I wish I could answer that question. We have not yet been told. I will answer it this way. If we are given an allocation to do so, absolutely, we are committed to vaccinating anyone that they allow us to and give us an allocation for. Allocations have not yet been determined beyond phase 1A as far as who they will be given to and for what population. So is the hospital willing and ready to help? Absolutely. Do we know if we're going to be allowed to? Nope, not yet.
I appreciate that. What about the new CP joining Sonoma Marin Health? Is he or she going to be based in Sonoma?
And the new who joining?
Primary care physician. We're recruiting. I understand there's one in April that's coming through Sonoma Marin Health, the new primary care physician. And are they going to be based here in Sonoma?
Okay, so you were speaking of the one that was slated to join this, the Marin Health Sonoma-based family practice.
I guess that's the one.
Okay, there was someone who was slated to join in June, and I did receive notification within the last month, I believe, that that person withdrew completely. So at this point, they are reassessing if they and when they would like to do another recruit. Their numbers have changed somewhat based on someone going from part-time back to full-time since that decision was made. And so they're on a kind of in a holding pattern to reassess their needs, and then we will work with them for another joint recruit if that's what they desire.
All right, thanks. Last thing is a new state regulation. Are we suspending non-essential surgeries because of the surge, and do we expect transfers from other hospitals if needed, according to this new state regulation apparently yesterday, I think it was?
So there is a new CDPH order that did come out on the 5th and 6th. There was a slight amendment on the 6th. It's 2 parts. The first part addresses elective surgeries, and the way it states is basically if there's a 0% ICU capacity in your region under the stay-at-home order and a less than 10% ICU capacity in your county, then we are mandated to stop all tier 1 and tier 2 surgeries as referenced by a particular scale that's been developed. What that translates to Sonoma Valley Hospital is if our region and county reach those numbers, we will be only doing emergent surgeries because all of our routine surgeries would fall into those 2 tiers. So we will not have a choice if we reach that. The number I think I just saw was about 3.5% for the region. So we're not there yet, so it doesn't qualify. And the county is maintained higher than that. So will this happen? I don't have a crystal ball. The predictions say yes, we will hit that in the next month. But if everybody can stay at home and squell the surge, maybe not, I'm not sure. The second part of that is transfers. That, again, there's requirements around this. This is the theory that, LA is overwhelmed, certain areas, or can we share with hospitals like Sonoma that may have a few beds from hospitals that are truly out of beds? And is that going to happen regionally or farther with the great state of California? There's a lot of questions around that order, and it's being revisited. There's several calls that will be happening on Friday and from a legislative structure. So I expect that to be amended. But as it currently states, if you're adopted crisis care standards, which you can now find on our website, and there's a whole list of things you have to meet as far as level of overwhelm, basically, to adopt those, then at that point, you can call a centralized number and request help in placing patients that you can't care for. And if you're on the receiving side of that, which is we're more likely to be at this time, then we cannot do a financial check or any other check as a requirement of admission. We can only look at whether or not we have a bed and appropriate staff to care for that patient. And if so, we have 1 hour to accept them. And we are fully prepared to accommodate that request. And we've distributed information on both subjects to all involved.
Okay, thanks, Sabrina.
Any other questions for Sabrina? Thank you, Sabrina, as usual.
Oh, sorry, let me make a comment.
Sure.
Thanks for your comment of vaccination. But, and I'm sure you'd be the strongest possible advocate, for our community and our population in exploring other sources of vaccine. The story in the IT seemed to indicate, and things can get lost in the newspapers, that the general population probably wasn't going to be vaccinated until the summertime. Hopefully that's not true. But of course, what always occurs to me is our particular demographic, which I think we've got 25% of the district population, which is over 55,
65.
which would be about 10,000 people.
Over 65.
Yeah. Anyway, many thousands of people over 55, and therefore some thousands like me over 75. And so this is a high risk population. I know CDC has its well thought out and considered populations and numbers and all of that. But I think really we've got to do the most we possibly can and get these vaccines to our older population here. We can't wait around till last spring, to the spring or to the summer. I'm sure
Maybe
you share that attitude.
Yes, I can clarify that a little bit for you. The word is caught up in general population, and I think that's a poor term. If you look at the phases that have been outlined on the CDPH and the Sonoma County websites, the phases, the terms are misleading. Let's leave it at that. In the next phase at this point is some combination of probably essential workers, and how those are defined is still being rolled out. And it may also in that phase include individuals over 75. I haven't seen a final determinant on that. The phase beyond that, the 1C, will be most likely individuals 65 or older, or it could be a slightly different age cutoff with a certain list of comorbidities, and that is already quite specific. Then beyond that, I haven't seen real specific plans, but that's when you start probably more the term general population comes into play. So when you're talking about the elderly or people with comorbidities or people who absolutely must leave their home every day to go to work, those people are already planned to be in this next immediate future. The question for us is, are pharmacies going to be given that allocation and told to go there, versus are we going to partner, which we're actively looking at with other local agencies such as the health center, the fire department. We're already having these talks and rapidly moving forward with these plans that if you'll give it to us, we will take on these groups for you. So those are the questions still, is who's going to get how many doses and in what time frame, so that we can give you a scheduler and say, we got plenty of people who want to poke and monitor you. That's not the problem.
Well, that's great. Yeah, because the city of Sonoma is the oldest city in the county, and our area is probably the oldest. Now, that's maybe a difference between an average age of 45 versus an average age of 40. But it is at the other side of the curve, a lot of older people. I mean, you're talking about critical, just observing, vaccinations in, and we're talking about thousands of that are 75 and older, and even over 65. So I appreciate your work on this.
Great. Any other comments or questions for Sabrina? Ken, as our CEO, take us through the administrative report.
Thank you, Joshua. I think Sabrina's covered most of it, but just to officially report that Sabrina and I basically have taken over Kelly's responsibilities effective January 1st, and both of us are now on the UC payroll. So far, I think we've worked pretty well together, and I think we've got a lot of support from the administrative staff. As Sabrina mentioned, UCSF has been very instrumental in the recovery effort. From the financial side, we are now sending out statements and bills and claims to the insurance companies, and we're starting to see positive cash coming back. Just to expand a little bit on the 1206B clinic, Meritage is taking a significant risk in terms of managing the clinic. They're going to subsidize any losses up to a certain amount of money. And on the breach notifications, as Sabrina mentioned, employees have been notified to the effect that some of their information might have been compromised, and letters have gone out to the employees as well as patients. I don't have much else to report this time, as Sabrina covered most of it, unless anybody has questions.
If not, let's segue to the financial report. Ken and his
probably-
other hat.
That's probably more interesting anyway. You can turn to page 2 of the cover memo. With the system down, we finally got October financials out to the Finance Committee. We should have November by the end of this week, and December by the end of next week. But in terms of October, we can see Medicare was at 56.8% versus a combined 55.4% for Medicare and Medicare Managed Cal. Medicare, I mean. Medi-Cal was at 15.2%. Self-pay, which I'm a little surprised that did not go up, is 1.8% versus the 1.9%. And commercial was on target with budget. In terms of the cash, the October goal was $3.2 million. We actually collected $2.4 million. Year-to-date cash goal was $11.8 million, and we're currently at that point in time was at $11.7 million actual. Days cash on hand averaged 60.1 days. Prior month was 63 days. We will see that drop in a little bit in November, and in December we received the partial tax money, so it'll jump back up a little bit. Accounts receivable went up to 53 days. All of that's because we were not getting bills out the door, claims out the door. Accounts payable, we allowed to increase to $4 million. We allowed this because we just didn't know what the impact was going to be on cash coming in from claims in particular. Accounts payable went up to 58.3 days versus the prior month of 40. We're trying to keep that around 45 days going forward. Any questions?
Did we communicate, hey Ken, did we communicate with any of the vendors who, at least the larger ones, to tell them why there may be some delays?
Yes, we did. We did. Particularly the ones that provide us medical supplies. They usually have a cap on, but they understand what we were going through.
Got it. Good.
If we can go to the financials themselves. Which is page 49 of the package. As we can see, all of the services were down significantly. Inpatient, outpatient due to volume. Emergency room, we had 696 visits versus 990. Going forward in terms of the budget process, which we start making our assumptions next month, it's going to be kind of hard to estimate going forward into the next year as to how ongoing volume is going to be affected by the decreased volume, particularly in the elective services. Deductions from revenue were better than budget because the revenue was down by $4.2 million. And then line 16, total operating revenue was $346,000 short of expectations. With regards to the expenses, the only significant variance was on line 24. It was $90,000 over budget. All of that had to do with the PG&E catch-up on bills. The net result on the operating margins, we had a loss of $733,000 versus an anticipated loss of $576,000. Just for informational purposes, in the preliminary looks at November, that we probably have a $400,000 to $500,000 variance, although December looks better than November so far. Going on to the next page, getting to the bottom line after the GO bonds, we had $164,000 loss versus a $10,000 gain. On the very last page on the cash forecast, as I mentioned in December, we did receive, this was anticipated in this cash flow, but we did receive the partial tax money, and we'll again receive about a little over $1 million in April on the partial tax. And so if we can pick up the cash a little bit and pick up the revenue. We should end the fiscal year with 75 days worth of cash. I'm happy to answer any questions.
Questions on the financials for Ken? Obviously, we'd like to see some volume pick up and revenue pick up. And
frankly, from my perspective, it could have been worse. It wasn't as bad as I thought it was going to be.
In terms of the financials.
In terms of financials, yeah.
Yeah, yeah. I agree. Great. Any board comments at the end? I know it's been a long meeting. Sorry, guys. Really appreciate it. Thanks so much. Looking forward to our meeting in February, and I know we'll have the first meetings of the various committees of the year this month. And again, Happy New Year, and hopefully a better year than 2020 all around. Thank you, guys. Thanks, everybody. Thanks, Vivian.
You're welcome.